Welcome to the Institute for Global Engagement's Faith and International Affairs Conference Call Series. My name is Dennis Hoover, Vice President for Research and Publications at IGE, and I will serve as the moderator on today's call. Thank you to everyone on the call. I hope that you will enjoy and engage in today's discussion in health in Africa. I'd like to welcome our two to today's call, Woden and Dr. Eric Bing. Quentin Woden is an advisor in the education of the World Bank's Human Development Network, where he serves as cluster leader for equity, resilience, and early childhood development. His previous positions include manager of the World Bank's unit working on faith and development, lead poverty specialist for West and Central Africa, and senior economist in the Latin America region. He holds 2 PhDs, one in economics and one in theology and religious studies, plus additional graduate degrees in business engineering, economics, and philosophy. He is a prolific and widely cited author on poverty and economic development. Most recently, he served as guest editor of the spring 2014 issue of IGE's journal, The Review of Faith and International Affairs. A special theme is on faith-inspired healthcare in sub-Saharan Africa. Eric Bing is professor of global health at Southern Methodist University, and current appointment at the Bush Institute as senior fellow and director of global health. At the Bush Institute, Dr. Bing has initiated worldwide health initiatives, including serving as co-leader of the Institute's Pink Ribbon, Red Ribbon Partnership, an $85 million public-private program designed to combat cervical and breast cancer in Africa and Latin America. Before joining the Bush Institute in 2011, Dr. Bing was an endowed professor of global health for nearly 20 years at the Charles Drew University of Medicine and Science, where in 2010 he was named Professor of the Year. Dr. Bing received his medical degree from Harvard Medical School, and he also holds a Master's of Public Health and a PhD in Epidemiology from UCLA and an MBA from Duke University. His book, Pharmacy on a Bicycle, Innovative Solutions in Global Health and Poverty, was released in May of 2013. Before we start our conversation, I'd like to provide a brief description of today's call format. We'll begin with 10 to 12 minutes of remarks from Dr. Woden, followed by 10 to 12 minutes of remarks by Dr. Bing. Next, we'll have 5 or 6 minutes of dialogue directly between Drs. Woden and Bing, and then we'll open the floor for up to 30 minutes of questions from the audience. For the duration of the call, all audience lines will be placed on mute. If you'd like to ask one or both of our speakers a question, please press 5* at any point during the call, and you will be placed in the queue. Please note that this call is on the record, and an audio recording will be made available on the IGE website 24 hours after the call. So with that introduction, let's turn to our call. Thanks again, Quentin and Eric, for joining us today to share your expertise on the history, current realities, and future prospects of faith-inspired healthcare in sub-Saharan Africa. Quentin, we'll begin with you. The floor is yours.
Thank you, Dennis, and thank you for this opportunity to participate in the webinar. What I would like to do is very briefly explain where this project and the special issue come from, and then share with you some of the main findings. So where does this come from? The work started at the World Bank. We had a program on faith and development, and one of the key questions that we are trying to answer is, what is the magnitude of the role of faith-inspired healthcare providers in the world and in Africa? This is a very important question for us because we do support governments, but we also realize that we have a very large private sector, much of which is made of faith-inspired healthcare providers. And we had actually very little empirical evidence on the magnitude of these providers and whether they reached the poor, whether they were costly or not for households, whether they were doing a very good job or not in comparison to other providers. And when we started this project about 3 years ago, the literature essentially was saying that these faith-inspired providers were very, very large. Often people were saying that they represent 30 to 70% of the faith of the healthcare systems in the country. There was also a perception that these providers were making efforts to reach the poor and often were located in very poor and rural areas where governments would not be able to reach the population. There was also a perception that the providers were providing services at very low cost, in part because of the motivation of the personnel. Finally, there was a perception that the providers were providing services of high quality, at least in comparison to public providers. But while a lot was said about this sector, the empirical evidence on which these perceptions were based was rather weak. And so what we tried to do is to use in a systematic way household surveys that existed in many countries. These were nationally representative surveys, and we tried to analyze the data in those surveys. And so we found for about 15 countries that the surveys did have questions on where households were seeking care, whether they were going to a public provider, a private secular provider, or a faith-inspired provider. That enables us to look at market share, at who the providers were serving, at their cost for households, as well as the satisfaction. In some of the surveys, we had measure as to whether the patients were happy or not happy, and for what reason, with different types of providers. And they're actually surprising, at least in comparison to the prevailing commercial wisdom. So what did we find? We found first that while it was true that in comparison to public providers, in terms, for example, of hospital beds and these kind of variables, the faith-inspired sector was a very large share in some countries of the total healthcare system. When you looked at the broader data, including other secular providers as well as, for example, non-formal providers of healthcare, the market share of the faith-inspired providers was much, much smaller than we would have expected or that people were believing. And you can look in the paper on that in the review. The market share is much lower, but let's say, for the sake of the argument, that maybe they represent 10 to 15%. That's still a very large share of the health services, but much lower than the 40 or 70% that some people had been quoting. And I don't have the time in my 12 minutes to explain where that difference comes from, but if you want to ask me the question afterwards, I would be happy to explain the main reason for that large difference. We also found that the faith-inspired providers were not reaching the poor in priority, but nobody is, meaning that neither the public sector, nor the private secular providers, nor the faith-inspired providers were able to provide, for example, a larger share of the services to the very poor as opposed to the better off. And this is not too surprising because you have cost recovery in healthcare. And so often the very poor will not go to a facility unless they really have to. But we did find that the faith-inspired providers were at least as pro-poor as the public providers, actually slightly more pro-poor. So that was good news, but still the majority of the services do not go to the very poor in those countries. Now, as I mentioned, this is related in part to the issue of cost, and we found, not surprisingly, that the faith-inspired providers, their services were more expensive for the population than the public facilities. They were often less expensive than the private secular facilities. Now, why is that? Well, it's again an issue of cost recovery, but also the fact that the public sector in healthcare provision benefits from state subsidies, and many faith-inspired providers do not. Even those who are very well organized, for example, in national Christian health associations, we have those associations in about 15 countries. Even when they are well organized, they don't necessarily benefit from state funding. Sometimes they benefit from partial funding, sometimes from no funding at all. Now, the very good news is that we did find in the data faith-inspired health providers were providing services that were of a higher quality than the other providers. Now, what does that mean of a higher quality? I mean, we have two types of data. We have one type of data from the household surveys, and those data suggest that the satisfaction rates of the patients are higher among the faith-inspired providers than among the other groups. We also did actually detailed qualitative work in 2 countries, in Burkina Faso and Ghana, and we found that in both countries, really patients were explaining that the respect for the dignity, the way people were welcomed and listened to and cared for was actually at a high level of attention, if you will, or quality among the faith-inspired providers, according to the patients directly. Now, that's a very good news because what is much more important when we think about policy towards those providers is not so much the market share. It is a reach to the poor to some extent, but the issue of the quality and the fact that by providing better quality, those providers are able to also increase the demand for care and therefore improve the health outcomes of the population, that is really fundamental. So the conclusion then was that out of the 4 conventional wisdoms that I mentioned in the beginning, very large market share, primarily reaching the poor, not costly for households, and very high quality, the 4th one clearly was validated by the data, the other 3 less so. Now, what's the implication from all that? One question that we have at the World Bank, that other donors and governments have as well, is to what extent should we provide more support to faith-inspired hospitals, faith-inspired clinics, and other types of providers. At the World Bank, it's not very easy for us to do it directly because we work mostly with governments, but other donors can do it directly, and we can also have a dialogue, and I can give examples of that, with governments where, through the governments, we can provide some support. Well, the analysis suggests that, yes, by and large, from the point of view of the quality of the services provided, there should be more support for faith-inspired healthcare providers. And there are some countries where this is working very well. Again, I don't have the time in my 12 minutes to explain that in details, but Ghana, for example, is one of the countries where you have a memorandum of understanding between the governments and the Christian Health Association of Ghana that works very well, and where the Christian Health Association receives support and is also a full partner at the table when policy decisions are made for the country. So what could say, but don't you run the risk in supporting faith-inspired healthcare providers to have a number of complicated issues associated with that? So one issue would be the issue of proselytization, and that actually, at least in the quantitative data that we obtain from facilities in Burkina Faso and Ghana, did not seem to be the case. So you would have, for example, a little bit of proselytism going on in the care provided, but this is fairly limited and accepted. And you would have, for example, patients from a Muslim background saying, yes, I mean, I'm going to the Christian clinic, and they do talk about God, but that doesn't bother me. And vice versa, when you would have Christian patients, for example, going to an Islamic clinic. Now, that is qualitative evidence. It's not large statistical evidence, but we didn't see too many problems. We also didn't see too many problems, although we looked less at that, on issues such as contraception and other kind of area where some religious faiths have very strong positions. But let me perhaps conclude here. I think I'm probably at the end of my 10 minutes by summarizing the main results of this work. And again, we are very grateful that the Review of Faith and International Affairs gave us a forum for sharing many of these results. So what are they? The market share is probably lower than many people believed. The reach to the poor is significant, but still, even the faith-inspired providers sometimes may have difficulties making their services fully affordable to everybody because they need to do cost recovery, especially when they don't get state support. The costs are a bit higher than the public sector, but that's the cost for the household. That doesn't mean that the cost of delivery is higher. And finally, the satisfaction of the patient is higher, probably because of higher quality. Now, if I may, then do I have another 2 or 3 minutes or not?
Sure. Sure.
Yes? Okay. So let me then mention one last piece of research, which is not actually part of the the Faith in International Affairs special issue, and not part of our own project. But this was one of the most interesting piece of research that a few colleagues at the World Bank did 4 or 5 years ago, maybe 7 or 8 years ago. What happened is that in Uganda, the government wanted to give untied grants to local health facilities. And these grants could be used by the facilities in any way they wanted. And these were faith-inspired facilities, essentially. And what the researchers were able to show is that instead of using these untied grants of about $2,000 per local health center, instead of using those for their own benefits, the facility or the benefits of the staff of the facilities, essentially the facilities provided more service to the population at a lower cost. And this then is leading to a fundamental question. There is strong empirical and also strong anecdotal evidence that many of the staff who are in the faith-inspired facilities actually have such motivation and such engagement that helps to provide better services and with dignity to the patient. The question then is, are these kind of models replicable in other settings? So what can other facilities, including public facilities, learn from faith-inspired facilities? So I'm just going to leave you with a question, and we can perhaps go back to it. But this is a fundamental question, because the issue then of what we can gain from the experience of the faith-inspired facilities is not only to support them probably better, because they do a good job, but also what can we learn for the larger public sector and even the private secular sector, which is not faith-based, which is in some respect at least as large. So what can we learn in addition from the way that the facilities work? If it's purely motivational, it might not be replicable elsewhere, but it's probably not only purely a question of motivation. So let me stop here.
Yes, key questions. Many thanks, Quentin, for sharing your expertise and more broadly for your leadership in improving the state of empirical research in this area. We'll now turn the floor over to Dr. Eric Bing, who will share from his perspective as a professor and practitioner of global health. Eric?
Great. Thanks so much. And thank you, Quentin, for that great overview and for all the articles that you have in that special issue. I'm primarily a health services researcher. So one of the things that I think that is important about some of the things that Quentin is talking about is that it really is sort of happening all in a global context. One of the things that we have seen over the past 2 decades is these sort of significant improvement in health in many developing countries, with also the sort of a growth of an infrastructure. With maternal and child mortality rates in many places, dropping in half. And a lot of that is due to better preventative care, as well as increased expenditure of resources in many of these countries. And particularly if you sort of think about sort of the infrastructure improvements, PEPFAR and the Global Fund, as well as other sort of business models supported by the Gates Foundations and others, have really sort of helped us change many of the dynamics of what's happening in many developing countries, which is not to say that there aren't still major problems that need to be addressed, and far too many people are dying, particularly those who are very, very poor. But there has been improvement. And I think one of the other sort of things that is along with that is also sort of improvement of in the economies in many of these places, where you have more demand for health services, particularly services that some people are willing to pay for, with the growth of these economies, and by fact that in some places there's not a lot there to begin with, and so people are demanding this. One of the things that we talk about, this is Mark Epstein and I. Mark Epstein is a business professor at Rice University. In a book we have called Pharmacy on a Bicycle, surveyed about 100 of these types of organizations, not just faith-based, but many different types of organizations around the world that are having impact. And a number of sort of key elements that we sort of identified was that those who were successful at affecting change were often innovative and entrepreneurial, really focused on maximizing efficiency as well as effectiveness, which is really quality. We're clear about developing partnerships, really strategic partnerships, had clear systems of accountability in what they were aiming for and what they would be reaching, focused on task shifting in order to reduce costs, and then also focusing on scaling. And I think many of the faith-inspired institutions that we have are some of them are actually being able to do this. And I think that as we focus more on sort of issues of accountability and lowering costs of care, people and organizations will be focusing more on ways of doing that. I think that not only are donors demanding it now, but also countries themselves that are expending more of their resources for basic health care. And one area that I think that faith-based institutions can really play a major role in, however, and that there aren't many players doing this is in mental illness and in mental health. There was an article in the special issue focusing on humanitarian issues in disasters. I think that's actually one area that they can play, but a bigger role is even in a disorder like depression, where we have 350 million people who are suffering from it at any one time, and where that it is one of the largest illnesses for lost disability years in the world. And because there are such good treatments now for depression, and there's a number of different models that have shown that these can be done even with community health workers, people who are trained in counseling or people who are trained in talk therapy can be trained in this. And I think it's actually an area that as we sort of think about how faith-based organizations can play even a greater role in health, I think this is an area that is particularly designed for organizations that do counseling and that do focus on the well-being of all the citizens. And so one of the things that I think is that that there's been significant growth in or improvement in what we're doing in health. Faith-based has a clear role to play. The fact that what we're seeing now with this good baseline data from the World Bank's study is that the market share is lower than one might expect, and the cost is higher. People are satisfied with these services, and this can actually be built on. So I'll actually stop my comments there, and perhaps now Quentin and I can have an interchange.
Yes, that sounds great. Thank you, Eric, for your insights as well onto this. And so we'll now have a few minutes of dialogue between the two speakers. They can ask each other any follow-up questions they may have. And Quentin, I'll hand the floor over to you first.
Okay. So one of the things that Eric said I found was interesting about the special ability, potentially, of a faith-inspired care provider in areas of depression and mental health and others. And I actually know some of the examples of great work done in very poor countries like Burundi on mental health, which is the only mental health hospital is faith-inspired. But this actually brings me to another point, and I want to make sure that the listeners understand that the work that we did at the World Bank was really about facilities-based care, right? A small health post, a clinic, a hospital, and things like that. And many of the people that I've discussed with over the last few years always point, and I think that's correct, that there is also this very large network of informal care that is being provided, where the role of faith-inspired group might be actually even larger. and this is, for example, support groups for HIV/AIDS, or support groups that come out of a congregation to help those in need, and things like that. And so that we don't have data. There are research projects starting to look at that, one sponsored by TIRFAN, which is called the Joint Learning Initiative. But I wanted to know whether, Eric, you have any experience with that, on the role that the non-facilities based groups, which are faith-inspired, play in all of this support to children, families, the elderly, and so on.
No, that's actually a great question. Thanks, Gwen. One of the things that you correctly point out is that a lot of the care that is being provided is not necessarily facilities-based, and much of the work that you presented was actually facilities-based. I think one of the reasons that it is accelerating is the fact that we have now technology. And you are able to provide care in the field with community health workers, with community-based volunteers, with support people who are then backed up even with cell phones or with checklists or with supervision by the facility or by trained medical providers. And that often isn't caught in some of the data because they are seen as part of the sort of the community outreach as opposed to the facility. I think there is a number of organizations that have actually been quite effective with this. World Vision being one that I've worked with before, being extremely proactive at using technology in order to provide care. And much of that is not going to be caught in facilities-based care because it really is community-based care. Right. And I think some of the models that we have in mental health, often it is going to be community-based care, and it may be with a traditional healer. It could be with a volunteer health worker. The critical area here, for quality's sake, is the importance of supervision and oversight by more trained providers so that they don't get in over their head. But I think all this sort of speaks to is sort of access to care, regardless of where it's being performed, in a facility or on a bicycle or on a backpack that a community health worker brings.
Right. So, if I may, so there's a great example of work done by a local non-governmental organization that's in Mali. It's called Musso, or previously Project Musso. I don't know if you have heard about it. Mm-hmm. And so they have a study showing that with very simple intervention based on outreach, essentially through community health workers, they have been in a period of 3 years in the area where they work. They've been able to reduce child mortality by a factor of 10. So it is stunning. At very low cost. And this then brings to me a second question that I wanted to ask you, which is that you mentioned in your remarks the importance of cost. I wonder whether that's the main driver of the gains. To me, sometimes it seems more that simple models, which rely on local workers, Musso I think is partly faith-inspired, by the way, which are low cost, just through the way they are designed, but which really pay attention to the connection with the patient, are not an important solution. So this is not an issue of reducing the cost of operating of larger networks. It is really an issue of maximizing the benefits from the local anchoring. And they are faith-inspired groups, because they are respected in their local communities, I think have a major potential role to play. What do you think?
I think you're right on. And I think that cost is a component, but certainly it's not the only component. Access is a key component, but it's also not the only component. Quality is a key component, but it's not the only component. Where I think this is sort of leading to is acceptability. And I think that's actually where faith communities can play a key role, because because they understand the culture and many of them understand the culture and that they're working within it, it will be much more acceptable for people to use them with all things being equal. It also may allow them to even have costs that are higher because they are so acceptable by the population. I think the same thing is true with traditional healers. It's not necessarily because the quality is better, but it's because they have tapped into the beliefs of the community. And traditional healers are by sort of definition entrepreneurs, and they are really making people feel comfortable in going to them, many of them. And so I think this sort of issue of acceptability and a person's level of comfort with the care is a key issue. Which sort of brings me back to a sort of issue that I wanted to sort of talk about with you in terms of the quality issue that you had talked about. I'm wondering if you might be able to say a little bit more about that, like how you measured quality or how people are measuring quality in relationship to faith-based, because the issue of satisfaction is one measure of quality, but perhaps another measure of quality is really outcomes. Are the outcomes better than in other places?
So I don't have the answer to that question because the measure that we used were subjective measures from patients. Subjective in terms of qualitative work, but subjective also in terms of answers to large-scale surveys where you ask, are you satisfied or why you're not satisfied? These are numbers, but subjective data. When I did talk to a number of people from the faith community, like Catholic Relief Services and others, I mean, they do mention that they do have some studies that show higher quality in terms of outcomes. I am not sure that we have already enough impact evaluation kind of studies that demonstrate that in a comprehensive way. Because I'm an empirical economist, I'm not ready to say it's yes or no. But on the question of the satisfaction of the patients there, I'm really ready to say. And that's still very important just to increase the demand for care, which is the first step, right? But on the quality of outcomes, I actually don't have very good data. It could be that some of my other World Bank colleagues have data. I just wanted to say one more thing before maybe we open it up. But I tend to be fairly favorable to the work that most faith-inspired care providers are doing. There are, of course, exceptions, and the same applies to traditional healers. And I mentioned that because, Eric, you were also fairly favorable. But there's also there are also some studies that show problems, and one of them, for those who have not seen that, is a wonderful documentary by Barnagee from MIT. That's the Poverty Lab, and I think the title is "The Price of the Disease." That shows how sometimes some of those traditional healer providers may sometimes provide something real, but sometimes not, right? So we of course we have to be careful that we don't generalize in whatever Eric or I are saying too much. Yeah.
No, absolutely. And just sort of tying the loose end back to sort of the acceptability and quality issue. I think with some of these, we do need to sort of be clear: is this a quality issue that affects outcome, or is it an acceptability that I like it, I feel good about it, I'm satisfied with it? I think because some of the traditional healer data that we see, it actually may be an acceptability. This really feels good to me, as opposed to it's actually quality care.
Thank you, Quentin and Eric. We will now open the lines for questions from the audience. As a reminder to audience members, if you would like to ask a question, please press 5*. And when it's your turn to ask your question, our call administrator, Lindsay Kunz, will announce your name and unmute your line so that you can ask it. Lines will be placed back on mute immediately following the asking of a question. If you are already in the queue and for any reason decide you no longer wish to ask your question, simply press 5* again and your name will be erased from the queue. And finally, for the sake of other callers, I'll ask that when you're called upon, please immediately ask your question rather than providing your own commentary. Lindsay, our first question, please.
Thank you, Dennis. Our first question today comes from Mr. Thomas Berg. Mr. Berg, go ahead and ask your question.
Hi, thank you. This is very interesting. Can you hear me?
Yes, we can hear you.
Okay, good. I'm a law professor at the University of St. Thomas in Minnesota. I work in two areas of law. One is intellectual property law, and the other is religious liberty. So if I could ask a quick question about both of those areas. I'm interested as an intellectual property teacher in the relationship between affordability / access to medicines and patent law and other kinds of intellectual property questions. And so my question has been, has there been any involvement of the faith community in the debate over affordability and its relationship to property rights in medicines? And if there's not been that involvement, is there a vehicle for the faith-based organizations to have some kind of input on that? So that's the first question. And the second question, I guess, is whether is how you see the possibility of moral conflicts with faith-based providers entering into these questions. Is there, for example, a conflict between the values of larger international organizations like the UN and some of the faith-based providers on issues that matter? One of you mentioned contraception. Just could you just speak a little more about that issue and whether you see that being a significant issue? Thank you.
Quentin, do you want to try that?
Okay. On the first question, I actually don't know, but I know somebody who might know, and you might know him. This is Thomas Boge from Yale, who is a philosopher and has done quite a bit of work on the issue of intellectual properties and proposals to try to deal with keeping incentives for research and creation while making the results of that affordable. So he might be a good person to talk to, Thomas Boge from Yale on that, but maybe Rick knows more. On the conflict between organizations such as ours and faith-inspired providers, well, it all depends. So the World Bank has very clear positions, for example, on a number of issues, including the importance of family planning, and we typically won't go into direct conflict with any religious affiliation because we don't work directly with them in terms of providing funding or services. We work through the governments. But what we have tried to do, and I'll just give very briefly one example on that. What we have tried to do is when we believe that the contribution of faith-inspired providers can be very beneficial, to try to encourage governments to work with those providers who are on the ground. So some of the bank lending, for example, for HIV/AIDS, that we have given to the governments has gone to faith-inspired providers. The community of Sante Kilio is one example. And another example I just want to mention, because it's an interesting one, is that one of the World Bank operations in Nigeria helped fund a small organization that brought together Christian and Muslim leaders to try to promote better acceptance, for example, among other things, of bed nets, vaccination campaigns, and things like that. That's called the Nigerian Interfaith Association. So I would say that the opportunities for collaboration are much greater than the risks of conflict. But of course, we have, on a number of issues, very clear positions. We stop here.
Yeah, and just adding to that, Quentin, I think those are great answers. In terms of the first question, I also don't know the relationship between sort of the issues of intellectual property and sort of how the faith community is or is not getting involved with that. In terms of in terms of the second question, in regards to these conflicts, one of the things that I think is important for most countries or all countries, as they create and support their healthcare delivery system, is that we look at the role of the government as really the backbone of that, and that others are going to be able to support that. And sort of using that, there will be places where the faith community or different faith communities will be able to engage, and others where they will not, based upon their own beliefs. And I think having that diversity from a government standpoint is critical. Being able to choose who will be able to provide care in accordance with what is acceptable to those who are there and running the country.
Thank you. Our next question today comes from Ms. Kristen Lundquist. Kristen, go ahead and ask your question.
Hi, everyone. My question actually goes to Eric. I was wondering, you mentioned the importance of counseling, and I was wondering if there were any faith-based organizations that you know of that are doing counseling particularly well or have been really effective on the ground.
Chris, that's a great question. I do not know, and I sort of differentiate sort of counseling from treatment that we know works. So, for example, in depression, we know that cognitive behavioral therapy works. There are other things that maybe sort of makes a person feel good temporarily, but may not make the kinds of difference in relieving the disorder. And I think so. One of the things that much of the literature shows is that when practitioners do particular types of therapies, they are going to be more effective. And I think as we involve the faith communities in mental health, one of the things that will be important is that they be trained to do the things that we have documentation that works. And that's not to say that they couldn't do other things as well, particularly in alignment with their faith, but they follow the prescription, so to speak, for the therapy itself. And so I think that's actually what's going to be really important. And so back to your original question, I do not know organizations that are actually doing it. What I was actually putting out was the particular role that they can play, given their historical role in counseling.
Our next question comes from Christensen Adedoyin. Go ahead, please.
Yeah, hello, good afternoon. I really appreciate what you guys are doing. My name is Christensen Adedoyin, and I'm a faculty at the School of Social Work at East Carolina University in North Carolina. And I basically work around faith-based social services with interest in Sub-Saharan Africa. So I really appreciate what you guys are doing. My question goes to Eric and the earlier presenter. Now, you just mentioned something about cognitive behavioral therapy. And I know that in the U.S., there's been this infusion of spirituality into cognitive-based behavioral therapy. From your experience on the field and in gathering data, have you guys come across any system in these countries you guys looked at where there are basically what I would call importation of models from evidence in the U.S. around faith-based interventions for these faith-inspired hospitals? And the second question I wanted to ask is this. What is the role that the religious leaders are playing? Because you talked about cost control, and you talked about the need for subsidies for these faith-inspired hospitals and providers. Are religious leaders, basically subsidizing or contributing to these hospitals? Those are the two questions I have.
And so I will respond to the issue of these different therapies. I think that what the data shows is that regardless of where you are, Asia, Latin America, Africa, Europe, the Americas, or in really even the different types of providers that you can have, whether this is a trained mental health provider or something else, as long as they are following the treatment guidelines, they will be effective. And so I see no reason why faith would not also be effective following these same things. It makes no difference whether it's almost sort of like you're giving a person a pill or a vaccination. It will be equally effective regardless of the provider that is using it, as long as they are doing it as prescribed. And I think perhaps Quentin can answer some of the other ones that you have asked.
Okay. So on the role of religious leaders, so first, it's important to recognize that they can have a lot of influence, not only on the service provision side, but actually more importantly on the behavioral side, or the demand for care, or the type of behaviors that people follow. And we recognize that very much. I mentioned the Nigeria example, but some of you may know that in the past, in some of the northern states, there were issues with campaigns of bedness and vaccination because local religious leaders were concerned that this might hide something else. So they play a very important role. They can be very influential and very beneficial. In terms of the history at the World Bank of that work, the faith and development work actually started through an outreach from one of our past presidents, Wilkinson, towards faith leaders. And we have had a number of high-level meetings with faith leaders. The last one was in 2009. To try precisely to discuss, not only on faith-inspired healthcare service delivery, but also on the broad range of other development issues. And while the World Bank was perhaps a pioneer in this, this is now also done by many UN agencies. I can give you more details if you want to, but so that role is very important. And so the question is how to harness it for development.
Our next call comes from Mr. Corey Bender. Corey, go ahead and ask your question, please.
Hi, thank you for this discussion. I guess my question could go to either speaker. I was wondering what the spread of Pentecostal Christianity in Africa, especially health and wealth or prosperity gospel, what effect that has had on the healthcare situation. Thank you.
I'm not sure I'd be able to answer that one. Quentin, do you have any data or thoughts on this?
No, there is a perception, again, that both for faith-inspired care, perhaps even more for schooling, actually, and all of the work that we did for healthcare, we also did it for schools, primary schools and secondary schools. So there's a perception that there is a lot of activity and growth from Pentecostal groups in the provision of services, but actually you don't have any serious data on it. So the question there is that this can be beneficial, but we have to make sure that there are structures in place to guarantee, if you will, the quality of the services that are provided. In the case of the Christian health associations that have been there for, in many cases, 20, 30 years, they have developed these mechanisms of essentially training and support within their members. So the members of the Christian health associations would be clinics and hospitals and things like that. So I'm not fully sure that the service delivery by Pentecostals is already integrated in those. And so there's a need probably to make sure that these structures exist to ensure the quality of what is provided.
Mm-hmm. And Quentin, do you know if there is much integration of these Pentecostal facilities and providers with the others, given that they are newer than some of the others?
My impression, but I didn't look at it carefully, is that, for example, they typically are not members of the Christian health associations yet. So that would be a partial answer.
Thank you.
Okay, our next question comes from Banke Adedayo.
Hello, hi. I work with the Tony Blair Faith Foundation and manage a malaria education program that trains faith leaders to work in interfaith to disseminate simple messages on malaria prevention in Sierra Leone. I'm interested in what you said about training faith leaders to ensure that they can spread messages that have documented posters that actually work. And I was wondering on what you thought, what your thoughts were on bringing on the traditional healers and how you could integrate faith healers into the discourse with standardized religions such as Christian faith leaders and Muslim faith leaders. Is there a way you feel that they can work together with traditional healers where it wouldn't cause conflict, especially in countries where you see similar numbers, similar proportions of Christian faith leaders, Muslim faith leaders, and faith healing communities or traditional healers?
Do you want to try? Want me to take a look?
Well, I don't know actually. I mean, this is a difficult question. I don't know of specific programs that do that or try to do that. I think that would be a very important thing to do. Now, whether the traditional healers should be more integrated with the faith-inspired providers or with the public system, that's another question, because many of the traditional healers might not consider themselves as faith-inspired, but it depends. So I don't really know of the kind of initiative that may have already been undertaken in that field. What is clear is that if you want to ensure quality, and again, I mean the movie by Banerjee at MIT is really revealing in that respect. In India, it's about India. I mean, you need to have some kind of process to try to integrate those traditional healers. But Eric, maybe you know more.
Yeah, well, and you know, just to follow up with that, you know, I think there are some places where, depending upon the country, you know, there will be, you know, prohibitions against the traditional healers, where other countries have more embraced them. So, for example, in Zambia, I think the faith-inspired institutions as well as traditional healers have been engaged in much of their HIV prevention care, but the government is running these programs or creating the coordination and partnership, and so it becomes sort of an equalizer for all of the different partners, which could be faith-inspired institutions, traditional healers, universities, and whatnot. I don't know of initiatives where the Christians or Muslims have directly engaged the traditional healers, but that's not to say that it isn't happening or that it couldn't work. I'm not familiar with them.
Okay, our next call this afternoon comes from Mr. Edward Cook. Go ahead, please.
Hello there. My question is just to understand better your presentations. Would you, in these 15 countries that you looked into, would you give us the breakout of what you call Christian faith groups? How many are Catholic? How many are Muslim? You said that the evangelicals might not be participating. How many are Muslims? How many are traditional healers and shamans and that the like? Just so I grasp what you're bringing forth in your talks.
Sure. So the way the analysis was done does not directly answer your question. Essentially, we used national household surveys where you have health modules. What those modules do, among other things, is that every time a person is sick or ill or injured, the person is asked, did you seek care? And then if the person did seek care, where the person and the answers depend on each country, but in those 15 countries or so, we can actually identify these three groups, which are the public sector, the private secular sector, and the private faith-inspired sector. Now, the questions in the surveys do not, in most surveys, go beyond that, meaning that you don't know if it's an Islamic provider or a Christian provider. If it's Christian, you don't know if it's a Catholic or other type of Christian provider. So in education, actually, in some cases, surveys go a bit further because there's a clear split between Islamic and Christian schools. So the answer that I provided in terms of the market share, the reach of the poor, the cost for households, and the satisfaction of the patients are for the overall faith-inspired providers. Now, what is though clear is that in most countries, the role historically that the faith-inspired providers have played, and mostly Christian providers, is larger than the role of Islamic providers. But again, this depends on the country. For example, I mentioned in the beginning of my talk that we got much lower market force for the faith sector than people used to say, and the issue is that the traditional measures of, for example, the share of the Christian Health Association in terms of bed nets as compared to them plus the public sector is only a small part of the overall sector. But in one of the other reasons why people have claimed very high market shares is the fact that most of the information on the hospital bed nets came from Anglophone countries, where the Christian Health Association, because of the English model of decentralization during colonization, that model allowed much more freedom by Christian missionaries to set up these clinics and these hospitals. In the Francophone countries, it's very different, and the role that even the Christian providers play is much smaller. So if you want to summarize what I try to say here is that first, the role depends, of course, on the colonization history. Then the role depends also on the type of religion practiced in the country. But you have, for example, this very strong split between the Anglophone Africa and Francophone Africa. But even in the countries, in some of the countries which are now quite potentially with a large population of Muslim providers, historically you had Islamic clinics. But this is really changing quickly, actually, because you have more support from the population for those clinics, and you also have actually funding that comes from the Gulf states or some of the North Africa states that helps in the expansion. And you see that to some extent in healthcare. You see it even much more in education, where you have a very rapid expansion of Islamic and Franco-Arab and different types of madrasa school throughout Africa. But still, it's still mostly Christian, but because of these historical reasons. Does that help?
I wonder if I could just ask you just one quick follow-up question, Quentin. Do you know anything about the Lusophonic countries, the Portuguese-speaking ones?
Mm-hmm. Yes. So the Lusophone countries, I think, are in between. Although most of the data that we had was not for the Lusophone country. To be careful in what I say. But typically, this would be in between the tradition of the English, where you have these large private networks, including the Christian associations, and then the Francophone, where in most of the Francophone countries, you have no or only equivalent Christian Health Associations. They're smaller. And the Lusophone, most of those countries, there are only a handful, right, in Africa, 4 or 5, but they were not part really of the sample. Why? Because the surveys distinguish enough to be able to do the work. But my guess with that would be that they would be in between the two.
Thank you.
Thank you, Quentin and Eric, for this very engaging and insightful conversation. I wish we could go further, but we're out of time. I want to also thank all of our callers for joining us today, and hope you'll join us again for our next Faith and International Affairs conference call, which will be on Thursday, May 29. The call will feature Dr. Elisa Autry, who's a noted sociologist of religion in East Asia. She's a global fellow at IGE and professor professor at George Mason University. She will be discussing the topic of religion and China's global influence. And finally, let me also invite all of you to send us your suggestions for other topics and speakers who you would like to hear from in future Faith and International Affairs conference calls. Please feel free to submit any recommendations via the same email address that you used to RSVP for this call. Thank you all again, and have a wonderful day.
Thank you.
Thank you.